So I want to just highlight again for Promises, all of our inpatient. So we have 7 inpatient facilities across the country. So we have one in Massachusetts. We have one in the state of Pennsylvania, which is where I am coming from. We have one in Florida. We have 3 in the state of Texas, one in the state of Tennessee. And then we have 2 outpatients that are freestanding in Georgia and in North Carolina. We included some of these pictures. Again, aside from that, these are beautiful opportunities and certainly beautiful facilities. When I do trauma-informed care trainings, I always start with, if you know somebody that is needing access to care. And so Promises is payer agnostic and also diagnosis agnostic. And so what does that mean? It means that we serve a patient population that has both private insurance, but also has Medicaid. It also means that we service those that have a primary mental health diagnosis and also a primary substance use diagnosis. So we are fortunate that we are able to service so many individuals for the specific care that they are needing and deserving. When I use these pictures, the reason that I like to do this, there was a research that was done for those that had been impacted with trauma on the likelihood of them showing up to treatment, which is essentially what we all want. Somebody struggling with an active substance use, somebody struggling with their own mental health. We want them to know that they are able to be able to access services and care in a safe way. What that research found is that when an individual, so if it's any of you that are trying to help one of your patients be able to access care, when they went through and showed them where they were about to go, when they walked them through the process of actually accessing care. So when you drive up to the parking lot, you're going to see a long driveway. So if I was to describe the ranch in Pennsylvania, and I said, when you come in, you will drive up a long driveway. You will see scenery on the right-hand side. You'll see scenery on the left-hand side. You'll continue to go up until you see a larger building up on your left-hand side where you can park and you walk in. What they found is that those individuals were more likely to show up because what it did is it alleviated some of the anxiety of the unknown. So if you are trying to help access care for somebody, if you are working with somebody that you know needs a higher level of care and an inpatient stay, I strongly encourage you to pull up our website or the website of where you are going to be referring somebody and walk them through what it looks like. If you have a family member that is trying to access care for their loved one, do the same thing in some of the same ways that I've described this in. I have a college-aged daughter. She'll be going off to college next year. And we went to the colleges so that we could see where she would be sleeping at night, so that she could see where she was going to be, right? We're asking individuals to commit a significant amount of their time in their own recovery process. And so just knowing normal anxiety that is associated with having to start something different, it's incredibly important as a trauma-informed approach to help them to understand where they're going to be, what it looks like, where they should expect to be able to walk in the doors. That is one of the first steps. So before I even get into this training, that's one of the first steps. So these are some of the beautiful pictures of our facilities. But again, strongly encourage you to be able to walk through that process with your patients and with their families to make that transition that much easier and safer. You'll hear that word frequently. I will say too, as a housekeeping, so this is a 2-hour continuing education. I am not going to take a break. So if you need to, again, certainly you are able to do what you need to do in order to be able to take a break, to get a little bit of coffee. But for a 2-hour continuing education credit, I'm just going to continue through. So this will end probably a little bit before 12 p.m. Eastern. I will allow for a little bit of time at the end for additional questions. But again, please feel free to put your questions in the Q&A. Those questions Callie will give to me so that I can answer them in live time. And then if you have any technical questions or concerns, then put those in the chat and Callie will be able to answer those as we are going through. So as I had said, this is the first. So we are super excited about offering. I'm thrilled about what we're able to do with PBH University here at Promises. So we are going to have 4 different series throughout the year. Each of those series will have 3 different topics. This first one is trauma-informed care and the importance of trauma-informed care in behavioral health. And so I am doing that first one. Next month, We will do practical applications of strategies and interventions in the gift of healing. So again, this is going to be an overview of what trauma-informed care is within an organization, within the way that we see and treat our patients, and the importance of this within our space. Promises I am thrilled to be a part of when I came here to make Promises a trauma-informed, family-focused, which you will see in that part 3, and skills-driven program to enhance our patients' outcomes. And so next month, it will be me again for those practical applications. And then part 3 of this trauma series is going to be one of my coworkers, Wendy Elliott, who is the corporate director of family services, and she's going to be talking about a trauma-informed approach in working with the family. So the idea of co-regulation. So please feel free to sign up today. I continue to encourage you to come onto our website to see the many opportunities and the different subject matter experts that we're going to be able to share with you. Super exciting time. All right. So then for us to get started, so the objectives are everything that I'm going to go over. So if you have ever done a training with me, you will know I don't go over the objectives because I go over them as I train you. So I'm going to skip over that slide. So for the first one, so this is an incredibly important part of trauma-informed care, is to have a basic understanding. So SAMHSA's concept of trauma-informed approach is grounded in this idea of these 4 assumptions. So when I go to our teams, because we are also a trauma-informed organization, which means that I've gone out to all of our facilities to be able to offer these trainings to our team members. And when I say team members, I mean everybody in the entire organization. If you are truly trauma-informed, it means that you know the importance of every human being in your facility, in the importance of somebody who's been impacted by trauma. Oftentimes, behavioral health will assume that the most important person in a patient's care is oftentimes the therapist. And for those of us that are therapists, we are like, yeah, sure, that we're doing a lot of the work. But in recovery, the most important person is the person standing in front of our patients. That's the most important person. And so that could be housekeeping. That could be a behavioral health technician or a recovery support specialist. It could be an alumni coordinator. It could be the CEO. It could be a therapist. Oftentimes it's not, ironically enough. It could be the chef or the cook in your facility. So to be truly trauma-informed, those assumptions are starting with that all people at all levels of the organization have a basic realization about trauma. So that when I say those words of empowering every human being in our entire facility, whoever is standing in front of the patient is the most important person in a patient's life. That we who have been in the behavioral health space know better than to think trauma doesn't happen in the hour that I have an individual session, nor does it happen in the 3 hours or 2 hours that we are running group. Trauma happens when they are waiting in line for lunch. Trauma happens after a very difficult phone call with a family member. Trauma happens when something in the environment has triggered them to a response from something that they have learned in their past. So to truly be trauma-informed as an organization, it means that you have to recognize that everybody is your partner within your entire organization, and you are all equally as important in the care of the patients that we are serving. And so that starts with this, that all levels of the organization have a basic realization about trauma and understand how it impacts families, groups, communities. That's the shift. That second piece, that everybody in the organization is able to recognize the signs of trauma. So we will spend a lot of time on that today. So how do we recognize the signs? Because the interesting thing about trauma, and I have been doing this, so I have been in the behavioral health space for about 27 years. So just as a little bit of a backdrop so that you feel confident that I know what it is that I'm talking about. So I've been in the behavioral health space for about 27 years. I have been extensively trained in trauma-informed care and trauma-informed treatment. And so many people will say, I really want to do trauma work. And I'm like, that's fantastic. Do you understand what it looks like? Because when we start to go over the symptoms of what it means when somebody has been triggered, oftentimes what happens is that we look at the signs of trauma in a punitive lens. So today, what we're going to talk about is how to recognize the signs of when somebody has been activated or triggered. That the program and the organization learns how to respond versus react. So when we understand what when we are able to recognize the signs of trauma, how do we teach our teams to respond versus react? That becomes another assumption and key foundation for trauma-informed care. And that ties perfectly into that idea of that trauma-informed approach seeks to resist re-traumatizing. So what does that mean? Oftentimes people will say, Trish, we know that we can't do certain things, right? We know that we're not supposed to do anything that would be re-traumatizing of a patient or a client. And I say, okay, but if we don't recognize what the signs are, and we haven't learned how to respond, and we react to a patient. And so I'm going to give you a couple of examples of individuals that I have worked with over the course of the years, just so you can see how trauma presents itself in a lot of different ways. If I engage in a reactive behavior towards somebody, teaching them that who are you talking to like that? I'm not, you don't get to talk to people like that. You need to behave better. Couldn't that be re-traumatizing? For somebody's story, couldn't that be re-traumatizing? And so the way that I always describe this is that when I see a behavior within our patients, I feel like I'm looking into a window to their past. I feel like I see the behaviors that have existed prior to them coming to me. So I'm not angry at them. As treatment providers, we do not condone or condemn behaviors. As treatment providers, we're supposed to provide opportunities for our patients to understand themselves differently so that they have choice in how they want to respond to their environment. Re-traumatizing is when we don't see that and we personalize behaviors, and then we try to teach them lessons. So when I go into my own teams, they will hear me saying, our patients do not owe us apologies. Our patients are not here for us to teach them manners or etiquette or how to be polite. In an inpatient treatment facility, our patients are here for us to help them to realize that they have the right to recovery, that our jobs are to give them the space that they get to decide if recovery is theirs, not to teach them manners, because in a hierarchy of survival, which we will talk about when we talk about the brain, etiquette doesn't matter. And so that requires a lot from us as individuals within the field, as coworkers, as leaders, to really be able to support our teams in understanding that place, because too often the behaviors are personalized, and then we learn how to react to our patients as opposed to responding. And this is too serious for us to continue that way. When we look at the guiding principles of SAMHSA's trauma-informed care, we are looking at the 6 core principles. And so I'm going to spend a little bit of time on this, but not to the extent so that I can continue to move on. But when we look at it, safety. So not just physical safety, but when we look at it, so when I talked about making sure that you are showing your patients the facilities that you would be recommending that they go, you're showing the families that that's providing them emotional safety, psychological safety. So when I say that, again, physical safety certainly is paramount. But when I think of like the emotional and the psychological safety, it means that when our patients engage in a behavior that they too wish that they didn't engage in, that we don't shame them for it. That we recognize the signs of trauma and we learn how to respond to them differently so that they don't shame themselves for a behavior that they have learned worked. So you're going to hear me say that even more as we get to like the brain. But when we talk about the brain in a triggered state, the phrase that I use all the time is that in a triggered state, and we will talk about what that means, right? Understanding the differences of our brain states. In a triggered state, the brain decides what worked. Not what's good or bad, not what's right or wrong, not what's moral or immoral. In a triggered state, our brain decides, did this work? And so when I had said that when I see a patient engage in a behavior, I assume that that behavior has served them in the past. And so I feel like I'm looking into a window into their past to say, okay, I see what's worked for you before. I don't need to shame them. That when we look at trustworthiness and transparency, it becomes incredibly important that you are forthcoming with your patients, that you say what you mean and you mean what you say, because trust is at the root of trauma-informed care. And if we are not fully transparent, then our patients are going to have to make a decision in that moment. Do they trust you or do they trust themselves? So it requires us to be incredibly forthcoming in that idea. That when we look at peer support and mutual self-help, trauma-informed care means that you are involving the community, the peers, that sometimes in behavioral health, we overinflate our own importance at the expense of our patients needing to be grounded within their own support. So when you talk about, again, Promises has a very robust alumni programming, that's peer support. That we want our patients to be able to trust each other within their own communities, to be able to build their community of support and recovery support, that's a foundation of trauma-informed care so that they don't learn that the only place that they are safe is in our care. So while I want our patients to know you are safe when we are treating you, what I don't want their brains to learn is that we are the only safe place for them. Because in a triggered state, again, the brain makes very quick decisions of what worked. And if they learn that the only place they've ever felt safety was in the treatment of our own space, then what can happen incidentally is you can institutionalize somebody. Because when they go back out into the community, if you did not build their peer support and their mutual self-help, if they don't have a community to find safety in, then their brain is going to continue to try and find safety in your treatment space. That when we look at collaboration and mutuality, it means that the patient is an active participant in their own treatment planning, in their own goal setting, and in their own navigation. This does not mean that whatever the patient says is what we do, right? So that's a confusing word for a lot of people. Patient-centered is not doing what the patient asks all the time. It's doing what's in the best interest of our patients. That's patient-centered. And so if a patient were to engage in a behavior, I'm not going to override them. But collaboration and mutuality means that I'm going to have a very honest and transparent conversation about my concerns associated with the behaviors that they might be engaging in. A perfect example would be family. So patient says, I don't want to involve my family. Collaboration and mutuality tied in with trustworthiness and transparency is me saying, I have significant concerns that if we don't involve your family while you're in our care, that this is going to make it that much more difficult for you to manage your recovery when you get discharged. So let's have an honest conversation about what's going on with that. That's the shift. Empowerment. There is one question, so I'm going to come to that in 1 second. Empowerment, voice, and choice. So again, I want our patients to be able to get into their cortex. We are going to talk about that. I want our patients to appropriately advocate for themselves. I want them to have voice because this is what they have to learn in order to be able to manage the recovery. So in a facility, it is imperative that we provide opportunities. That doesn't mean that they always get to have their say, but it means that we are going to provide them opportunities to find their own direction within their recovery in the safety of the parameters. And so if I need to explain what that means to a patient, that's exactly what I do. So one example is oftentimes, depending on your treatment facility, some patients can't have access to razors. Sure. Empowerment, voice, and choice is that when a patient says, I want my razor, I can't believe this is ridiculous, I can't have access to it, instead of just saying, these are our policies, this is our rule, which can feel like you're marginalizing a human being, empowerment is, can I help you to understand why these rules are here? Can we talk about other ways that you can get your needs met in ways that doesn't compromise how we have to ensure the safety of everybody in this facility? That's the shift in the languaging. And then cultural, historical, and gender issues that we have self-educated ourselves, trained our teams about the importance of cultural diversity, of historical natures of where an individual has come from and how that might be presenting to them today and their gender issues. It is not our patient's job to get us to understand them. It is our jobs to ensure that our teams understand our patients from our trainings. So it can't be where our patient is going to feel that they have to be able to educate somebody on any of these issues. It is our responsibility that we know that when we value somebody's differences, when we value somebody's cultural history or their gender, that we provide a level of safety that allows for them to manage their recovery. So a couple of questions that have come through. What if you don't trigger the person that's traumatized, but it just happens? Yes. So that is a great question. So the irony of that is when I first started doing trainings for trauma, and again, this was many years ago, somebody had asked me to come into their facility and they were like, can you train everybody how to avoid the triggers? And I said, I don't think so, because triggers are individually based. And so that would mean that if I went into a facility, I would say, listen, men, I need you not to be able to raise your voices. Women, I need you to not raise your voices. You can't wear cologne. You can't wear perfume. You can't have high heels. You can't have, because individual triggers are so individualized. There's no way I could sit on this training and ever train you how to avoid triggers. But what we can learn is how to recognize when someone is triggered. That's what this training is. So for us at Promises, again, when I came in here, I created a whole new curriculum for them. And these 3 R's that I have kind of identified that are some of the critical pieces. We're going to talk about the trauma competent 3 R's, but for our curriculum, I had identified the 3 R's that we're going to be focusing in on is to recognize the signs that somebody has been triggered and for our patients to do the same, to get themselves regulated so that they have the choice to respond. So when you're asking the question, how do you recognize when that takes place right away? That's this whole training. You're going to start noticing how to recognize when somebody is triggered, even if they don't know why. The thing about trauma work is that most of it is so below our level of awareness that we might not be able to get them to understand when they were triggered or why they were triggered. But could we help them to recognize how they notice if they are? Changes in their physiology, changes in their thought processes. So that's what we're going to actually be talking about today. How do we process their emotional state in that moment when identifying with what they feel is a new trigger, and they are unclear of how it is affecting them? So here's the beauty. Depending on the level of care that you are, and so this is going to be where there's going to be a shift, right? So the whole idea behind this training is to shift the lens. So these questions are fantastic. Because it means that you are thinking about your patients. So this training is going to be so that we can understand how to recognize the signs if somebody is triggered. What I'm going to say very clearly, our patients don't need to know the why right away. The patients also might not even know the why they were triggered. Recovery is not about knowing the why. It's about recognizing when. And then regulating themselves. So again, I have a small private practice that I've been doing for years and years. And there would be individuals that would come to me that have been in their own recovery program for sometimes up to 15 years, managing their sobriety, but all of a sudden things start coming up for them. And they were like, why haven't I dealt with this years ago? And I'm like, I don't know. Maybe you weren't ready. But the reality is that you were engaging in skills to be able to continue to move through life. So if today you're ready to start diving into a little bit more of the narrative of your trauma, it shows that you have the skills and the tools needed to be able to start this journey. So you're going to hear me very clearly say, trauma work is not just about that narrative. And in sometimes, particularly in an inpatient, it's too soon to do the narrative. Trauma-informed work is getting patients to be able to recognize that they have been triggered, to giving them the tools and the skills that they independently can get themselves regulated in a way that allows for them to have choice in how they respond. That's the shift. So when we're looking at trauma-informed care and trauma-specific treatment, those can be simultaneously. They also can be different. So trauma-informed care is that whole global getting everybody in the organization trained, making sure that everybody understands how to recognize the signs of trauma, what the realization is and the impact that it has on our patient population, and then how to respond differently. Trauma-specific treatment can include DBT. It can include narrative therapy, right? There's opportunities, but sometimes people think that it's the same. Trauma-informed care can start the process. So when a patient comes into an inpatient level of care where they had just been acutely in crisis, whether it was using a substance that could have killed them, whether they were engaged in self-harm that also could have killed them, 5 days later, they're wanting to talk about a trauma, that this is where patient-centered care is doing what's in the best interest of the patient, not what the patient asks, that I'm going to pace them. That in these moments, I'm going to say, listen, there's a lot that you need to figure out, right? And there's a lot of opportunity for us to be able to do more work. But today, we're just going to start building you the skills so that when you find that you are getting triggered, you have skills to be able to re-regulate yourself so that you have choice in your responses. That's the shift. There is another question, so I'm going to tie into that. For the person that asked the question, some families, if involved in treatment, are triggering, right? That is also true. So I would highly encourage you to attend the series 3, which is family focused. So here's the thing with families. Sometimes in treatment, we are trying to provide treatment to our patients that we want our patients to live in. So we create a world that we are going to provide treatment in the insulation of what our treatment facility is, but not in the context of the system that they're about to live. So is a family triggering? Potentially, right? But if we don't involve the family in the safety and in the experiences of trauma-informed care for both the family and the patient, their highest risk is when they are reunited. And so I'm not doing treatment to protect the patient from the life that they are living. I'm doing treatment to help them to the best of my ability to support them in the life that they are choosing to live. So if a patient that says to me, my family is triggering and I don't want them involved in my treatment, and I say, where are you going home to? And they say, my family, I'm like, then we need to have a conversation. Because my concern is that if we block that out, this is a relationship that is incredibly important to you, and we need to be able to support that relationship as you navigate through this. So it shifts it. So again, I highly encourage you to attend that training, the 3rd series by Wendy Elliott, who will be talking specifically about this. So the responsibilities of trauma competent professionals. So do no harm by intentionally or inadvertently triggering flashbacks, right? This goes back to the question, how do we know? I'm going to show you what the symptoms are, right? And so we might not be intentionally doing these things, but it is going to be inadvertently that something might happen, that we recognize a patient has been triggered. The way that we respond versus react is going to be the direction of the difference between trauma-informed care versus a non-trauma-informed approach. And so when we start looking at some of these other ways, right, be intentional with your interventions. So another thing that I say to our teams when I go out to all of our sites and have these conversations is, how many of you have identified what your patient's coping skills are? Sorry, I'm drinking a little bit of tea for my throat. And they will say, yeah, our patients know their coping skills. All of you sitting on this call right now, if I were to say, what are your patient's coping skills? I'm going to argue that most of you are going to say the same 5. Breathing, exercise, journaling, coloring, and music, right? Same thing. So here we have close to 400 people on this call, each of us working with a patient population over the course of the years. So we're talking thousands of individuals who have the same coping skills, yet their individual experiences are incredibly different. So when we say be intentional with the interventions, when I came to promises, I was like, we're going to load up our patients so that they understand the differences in the interventions. We are going to talk about that today. We're going to go into more detail with this next month in the strategies in the interventions, because our interventions should be based on their brain states. Most of what we are asking our patients to do are not at the level of acuity that the patient is currently in. And so those skills don't work unless the patient is already really regulated. So being intentional becomes incredibly important. And so when you're looking at the responsibilities of a trauma competent professional, the 3 R's that trauma informed care looks at is when you are interacting with a patient, these are the stages that you should be interacting. So first, you should be regulating with them. So do they have the skills to be regulated? Do they have the skills to understand what that even means to get regulated? Then you relate to them. You can connect with them about why they are here. You can connect to them about something that is important to them. At the very last, the last thing that we should be doing in an inpatient, I'm going to argue you almost never even need to get here, is reason. But when you think about how we engage patients that are clearly telling us that they're triggered, oftentimes we start with reason. Don't you want recovery? Don't you want it? Like this is the same thing. You're self-sabotaging. If you don't do these things, this is what's going to happen. Don't you, you got to be able to work with your family. Like we start reasoning with them. But what I'm going to tell you is understanding the brain state will indicate that reasoning occurs in the cortex. And when somebody is triggered, they're not in the cortex. So then we start with just regulation. That's where we sit. Because if we can help somebody to get regulated, we will help them to get themselves closer to their cortex so that they can have choice. But too often in behavioral health, we start with reason. And what we know for certain is that it actually triggers our patients more. For any of you that have had a conversation with a patient who is actively triggered, and you start reasoning, don't you want recovery? What's going to happen to your kids? You're going to lose your job. What you actually see is the patient get worse because you're asking them to activate a part of their brain that's not even online. That we will talk about when we get to the brain. So what are the needs of those trauma impacted to know that they are safe from emotional and physical harm? So again, we obviously clearly understand that from a physical standpoint. I'm going to continue to urge you to think about this of, are your patients emotionally safe? Are you or your team reacting to them or are you responding to them? Because when a patient, now let me be clear too, because sometimes people will say, you don't know what it's like. So I have worked in the space for 27 years. I started working with adolescents and young adults. So welcome to the world of trauma. These were young adolescents that were removed from their homes for up to 18 months. You're removed from the home for 18 months, there's trauma involved in your life, period. Adolescents display trauma in very unique ways. So they are oftentimes very aggressive. They are oftentimes, very impulsive in the way that they respond. So if I personalized anything that would be said to me, I would likely lash out. So when somebody says something, right, that feels disrespectful, I need you to keep in mind, our jobs are not to teach somebody manners. In the hierarchy of life and in a survival skill, manners don't matter. We are trying to provide an opportunity for our patients to recognize that when you engaged in those behaviors, that's a sign you were triggered. Because for all of us on this call who have seen a patient engage in a behavior that we were like, man, they can't do that. When a patient is engaged in a behavior in front of you or to you, oftentimes what happens is they come back and they say they're sorry. Because they too have engaged in a behavior that they wish that they didn't engage in. This isn't how they want to be either. So if we shame them, if we try to discipline something that actually needs to be understood, then they're not emotionally safe. And for a patient that is trying to find safety, which is paramount to somebody that's had trauma, that's where you see your patients leaving against advice. That's where you see your patients not returning back to treatment. So we have to be able to look at that. We need to figure out, and again, providing our patients the tools to be able to get to a calmer emotional state. That's the focus. So the second I see somebody that gets incredibly triggered, I completely go into a different direction and all I focus in on is regulating them. So if I work with somebody that's actively suicidal, who starts to tell me that they are having thoughts, I no longer try to rationalize with them of like, what would happen to this? And how are we going to do this? In that moment, I completely go into a regulating state to help them to calm their nervous system so that they can get themselves back into their cortex to start making decisions. So when we look at trauma and substance use treatment, again, this is that most clinical programs address one or the other. Maybe not effectively, right? So for those of you that have been in the field longer than the last 10 years, we know that integrated care didn't even exist. If you had trauma, you went to one treatment provider, and if you had substance use, you went to a completely different trauma or a different provider. And today we're starting to get more and more integrated in the way that we provide care. But I will say that sometimes can be confusing too, because we still are telling our patients that the only way that they can manage the trauma is to share a narrative. And what I'm here to say to you today is that that is not true. I do not, and I am an expert in trauma. I do not do narratives with a patient until I see the patient has the capabilities to get themselves regulated without my prompts. Because what happens is that if they open up and disclose too much too soon, they will have only their thoughts when I'm not around. And I already know, based on the behaviors, because I've looked into their past, I know the behaviors that their brain is ultimately going to say, this will fix this. So when we look at trauma and substance use, again, let me be clear too, that substance use is whatever the solution is. So this is just as likely for somebody that struggles with self-harm, that struggles with suicidality. So the substance use is the solution. That's not the problem. So whether it was substance use, whether they engaged in self-harm, whatever it was that they chose to eliminate the experiences and the feelings, that became their solution. So you can put substance use out of that picture, and you can put any other behavior that your patient is engaging in light of that. So when we look at that bottom quote from Seeking Safety, I love this quote for so many reasons. Substance use, and again, you can replace that with any behavior. Substance use is the scab trying to protect the trauma. So for those of you working in an inpatient, think about what that means. That if I were to say, what does it look like when you rip open a scab? Right? Those of you would be like, it's pretty raw. It's pretty messy. It's pretty vulnerable, probably bloody. I go, yeah, that's what happens, right? You rip off a scab. That's what it looks like underneath. If we rip off the scab of substance use or whatever the behavior is, you should not be surprised by what you see underneath. So imagine if you ripped off a scab and the experts in the field were like, oh my gosh, why does it look like that? This is terrible. This is horrible. Why are you bleeding like that? Imagine your panic if the experts looked shocked. But that's what's happening to our patients when they display the behaviors. When we've ripped off the only coping skill that has protected the trauma from exposure. So keep in mind, the brain does not decide what's good or bad, right or wrong. It decides what worked. So if somebody is having active flashbacks, if somebody is feeling triggered, if somebody is feeling hopeless, if somebody is feeling agitated, if somebody is feeling high levels of anxiety, and they engaged in substance use or self-harm, for their brain, it worked. So when we rip off that scab, because sometimes you have to in order to really get it clean and healed, we can't act surprised. So I'm going to talk about some of the symptoms in a couple of minutes. But when you rip off a scab, when somebody comes into your treatment, you should expect the behaviors you see. You shouldn't be shocked or offended, because when you are, it's distressing to them because they're saying, you are the expert. Shouldn't you know this? So when I'm highly irritable, when I'm more frustrated, when I'm very agitated, isn't that what it looks like when you rip off a scab? Yes. So then we can't be shocked. That's the shift in the lens of understanding a patient's behaviors. So there are a couple of, how do you handle transference? Supervision. So if you are having transference, because again, we are humans treating humans. That's my phrase. I say this all the time. We are humans treating humans. And so we have real life human experiences, right? And the way that I would say it, if my kids spoke to me some of the times the way that I have been spoken to in the treatment world, I would have a very different conversation with my kids because I'm raising them, because I know where their story was, but I'm not personalizing somebody else's story who's accessing treatment. And so if I find myself, and that's the beauty of, like, again, our curriculum, we all say it, right? So recognize, regulate, and respond, right? Ad nauseum at this point, right? People are hearing those phrases because equally as important to us training our patients, we have to recognize that within ourselves. Transference is about you getting triggered by something. So supervision can be very helpful with that. So can also recognizing it. So again, if I were to use an example of when I would work with some of the adolescents and young adults, when they got agitated, and we use the phrase, you can't work harder than your patients, which feels like a cop-out, right? Because really, what does that mean? It means that your patients are struggling with something. So I'm not working harder than them, but that means that I'm noticing a barrier and it's actually pissing me off and I'm trying to push through it. That's the whole phrase when somebody says that. And so when I notice that in myself, if I even hear myself say that, like, you're working harder than they are, I actually am like, something is triggering you, Trish. And I have to get myself regulated and change directions. I then regulate myself and the patient. So instead of trying to hit a brick wall, I actually start to figure out, how did that wall get here and how else am I going to get around it? That's the shift. So I'm no longer blaming a patient by saying something like, I'm not going to work harder than you. Could you imagine a doctor saying that to you? If you had diabetes and the doctor saying to you, I'm not going to work harder than you. And you're like, but you are supposed to help me to understand what I need to do differently. Because if a doctor said that to me, I would feel like I was doing something wrong, but I'm actually coming to you because I don't know how to do it different. So those are phrases, again, that's transference, right? They're manipulating you. That's transference. They're triangulating you. That's transference, right? These are behaviors that the patient is displaying that somehow worked. I'm no longer personalizing it, but I see it. So when I feel myself getting agitated, if I can feel it in my stomach, but you got to notice it for yourself. If I feel it in my stomach, if I feel it in my head, I'm like, oh, they got me. I got to get myself regulated. I got to redo this. That's the shift. So how do I approach a resident who has trauma just when I approach her and say her name and that I need to speak to her? I'm not sure I 100% know what that question means. So if whoever wrote that, if you could just clarify so I can make sure I answer it. Is there value in acknowledging their apology when they work up the courage to apologize? So what I will say is that, again, I worked with adolescents and young adults who engaged in a lot of behaviors in front of me. And ultimately, the apology is because they don't want us to lose faith in them. So when somebody apologizes, what I historically say is, you don't owe me an apology. I appreciate that this is why you are here. So I'm not going to be like, don't apologize to me. You don't need to say that, because that doesn't make sense to them. And it does feel like that you are diminishing them. But it's really like, you don't owe that. I appreciate that you're thinking that you want to give that to me, but you don't owe that. This is why you're here. I know you also don't want these behaviors. So let's figure out what we want to do with that. That's how I shift it. Because I'm going to acknowledge it, but I'm not going to say that this is required. So when we look at a society in pain, so I'm going to say this, we're going to skip over. So again, an estimated in 2022, there was about 80,000 American lives lost from overdoses. Last year, there was over 100,000. So when we start looking at the rippling effects of substance use, and then when we look at mental health, oftentimes, particularly in an inpatient, people will say our patients are getting higher level of acuity. And so I'm going to say this as gently as I can. That's not possible, because we are required to do ASAM or locus level of medical criteria. A patient can't access care that does not meet the clinical criteria and medical necessity of our care. Now, having said that, we have changed as a result of the pandemic. So when I look at the implications of substance use, when I look at the implications of the mental health crises, we've changed. Because this means that today, more than ever, we might have been impacted by somebody that lost their life to substance use. We might have been impacted by somebody that has a substance use disorder today. We might have been impacted by a family member, a child, a parent who struggles with mental health. So while our patients haven't changed because they can't, we have. And so we have to be able to acknowledge that. For those of you that have worked through the pandemic, as much as we would like to say that's behind us, for those of us that are aware of how trauma works, it's still inside of our system. Every time somebody says the word COVID, people are having reactions to it one way or another. We are still living in the consequences of the trauma that we all lived through. And for those of you that worked through this, first of all, thank you for your service, because you were the unsung heroes that nobody acknowledged. Healthcare. We acknowledge nurses, as we should. We acknowledge teachers who stayed home. We acknowledge doctors, but behavioral health technicians, therapists, CEOs, clinical directors showed up to bear witness to the pain of somebody struggling with a substance use disorder and a mental health diagnosis, and nobody even saw you. So I see you, and I thank you for your service. You have been impacted. Our patients are the same. And so we have to be able to recognize that within ourselves, within our teams, that maybe I've changed a little bit. Maybe my nervous system's a little offset because I overnight became an essential employee when I thought I was setting up to be somebody that just believed in recovery. And again, I was in a treatment facility at the time of COVID, and I also see you because I remember the first day that I had to tell our teams we were going to be wearing full PPE. And I saw behavioral health technicians who were showing up to do their job. I saw therapists that were showing up to do their jobs. I saw housekeepers that were showing up to do their jobs at a time where they were worried about their own safety, where they were stripping their clothes in their garages so that they wouldn't expose their families. I see you, but you got to recognize this within yourself so it doesn't come into our treatment. Our patients are the same, but our world is different. That's how the mental health and the substance use crisis has impacted our work today. Not from our patients, but from us. So when we talk about the connection between trauma and substance use, and again, keep in mind, substance use can be interplayed with any other behavior of the solution. But I'm going to talk about the subtleties, and then I will get back to a couple of questions. But I'm going to talk about the subtleties, right? Because again, so much of trauma work people feel is the direct result of like these big ticket items, big people, places, and things, right? And we think that our patients have to know their triggers in order to recover. And I'm here to tell you, no, they don't, first of all. And secondly, if we are telling them that, we're actually setting them up to fail because there's no way for every patient to know every single trigger. So there are these big people, places, and things, but the majority of our triggers are well below our threshold of awareness. So when we look at how this connection occurs, so if a trigger occurs, and this ties back into a couple of the questions that have come through, if somebody is triggered, it can be anything, right? So it could be cologne, it could be perfume, it could be the sound of somebody's voice, it could be the scent of something. Anything is a potential trigger, right? That is very individually based. What will happen is a emotional or physical reaction. So it can look like sadness, it can look like anger, it can look like anxiety, it can look like guilt or shame that then produces, because we don't want to sit in those emotional reactions, and oftentimes we're not aware of them, it then engages in a quote unquote bad or an avoidant response. So that could look like I get physically aggressive because that backs people up. I could leave against advice. I could stop showing up to my treatment provider if they are outpatient. I can be avoidant. I can, right? So I can use substances, right? So those behaviors all the way on the bottom, cravings and substance use. I'm not even going to talk about those two things today, because the reality is that if we can get our patients to understand those first three things, then we're going to start opening up the opportunity for our patients to start managing their experiences before they understand them. Because the solution was when a patient was trying to do what they needed to do to not use, to not engage in self-harm. But eventually the brain said, we already have a solution that we know has worked, not right or wrong, good or bad, but what worked or didn't. So do it again. So I want to highlight some of the subtlety. And again, and very clearly saying our patients don't need to know what triggered them in order to start understanding if they noticed they were triggered. This is equally as important to all of us. This is why in a trauma-informed approach, everybody in the organization needs to be trained, because the reality is trauma doesn't happen in the hour-long session in a one-on-one, and trauma oftentimes doesn't happen in our groups. As I mentioned earlier, it happens when they're waiting for their meal. It happens after a difficult phone call. It happens in the evening milieu and on the weekends. So if we are training our patients and our teams that the only person that can help a patient during a traumatic trigger is a therapist, then we are setting up our patient to fail. So the subtleties of a trigger is, so I always use this as an example. So she just turned 18. That's disgusting to me, but she just turned 18 yesterday. So I have a daughter that when she was about 7 years old, she had asked me for a pair of high heels. So none of you know me, but if you did, you would know that I actually am somebody that wears like sneakers, a pair of jeans, a baseball hat, right? So on any good day, you're likely going to see me in a sweatshirt and a baseball hat. So for my daughter to ask me for high heels, it's kind of insulting, right? Personalized it a little bit, which is oftentimes what we do with anybody's trigger. So she asks me for a pair of high heels. I say, no, little girls don't need to wear high heels. Don't be ridiculous. She asked me a few days later for a pair of high heels, to which I'm even more offended, right? Which again, is typically us in the space of our patients when they are identifying their own triggers, right? So I'm like, no, little girls don't need to wear high heels. Like, this is ridiculous. Like, I'm not falling into this whole, kind of environment of like, girls have to do this, like go outside, go play in the dirt. To which she's like 7. She's like, I don't even know what you're doing, Mom. A week later, she asks me again. Keep in mind, I'm a therapist, right? So I should actually know a little bit better. She asks me again, and I say to her, why do you want a pair of high heels so badly? And she says to me, because the sound of them makes me think of you when you're not home. So when the only time I ever wear high heels is when I go to work. That's it. Outside of work, again, I'm in a pair of flip-flops, I'm in a pair of sneakers, I'm in a pair of jeans, and I'm in a baseball hat. So for her, the sound of high heels is a trigger that she's associated. So the emotional and physical reaction, she's associated those high heels to love, to feeling connected. So she doesn't engage in a bad or an avoidant response. What if I was an abusive mom? What would the sound of my high heels mean then? They would be of fear. They would be of anger. They would be of anxiety and shame about what she's done, because if I was an abusive mom, those high heels would elicit those emotional and physical reactions automatically stored in her brain. So then if 10 years later, she ended up in a treatment facility and she was standing in the lunch line waiting to be able to get her food, and somebody cut her off in the lunch line, but just a few minutes prior, somebody walked down the hallway with high heels, instantly her brain would be triggered. Now her body would start responding to that trigger, right? Her heart rate probably started to escalate. She was probably a little bit more agitated, but she didn't notice. So when the girl cut her off in lunch to get her meal, she lashed out. She either became physically or emotionally or verbally aggressive. Staff would run over and they would be like, why are you doing this? Why would you do that? You know you're going to get lunch. And she would answer in one of two ways. She would either say, I don't know why I did that. And then we hear staff that would be like, she's not here for the right reason. She's compromising everybody else's recovery. She's not serious. A judgment. Or she would say, that girl cut me off. Who does she think she is? That's disrespectful. I don't have. And we would be fixing the wrong problem. Because in that moment, why then? So that's the question I want you to constantly ask yourself when you see a patient engage in a behavior. Why then? Because is it the first time somebody's probably cut her off in the lunch line? No. Why then? And so why it's super important for us to help our patients to understand how to recognize their symptoms. It's also equally as important that we get all of our teams to feel empowered to be able to support a patient in the moment. Because if we think a therapist, I think I'm a pretty good therapist, if I'm being honest. There's no shot that I would have recognized that this was a high heel moment. That I would be able to come as a therapist and be like, you know what I think? Do you think it was the high heel? Like I saw this woman, she was walking down the hallway. She had high heels. That's when I noticed. I am very unlikely to have connected that for her. And even if I did, could you imagine if I said to her, you know what I think you're actually really angry at? The high heels. She would lash back out and be like, you think I'm crazy? Why do you think that's ridiculous? Because it doesn't make rational sense. Because trauma is not rational. It sits in an emotional part of our body and it is automatic and it's reactive. So we don't need to know why, but could we help her to recognize what it feels like when she is triggered? Yes. Could we help everybody in the organization to recognize the change in somebody's behavior so that we see when they are triggered? Yes. Then we provide them the skills to be able to regulate. I don't need to lecture her about not getting into a fist fight over food. She knows that. I don't need to tell somebody, you know, if you continue to use heroin, you could die. They know that. So why then? That is the question that we should be asking ourselves. When a patient starts to curse you out, why then? You assume that they're holding information from you, but they don't know either. How many high heel moments are happening to our patients a day? We don't need to know why they were triggered to help them recognize when they were. That's the shift in the care. So here are the symptoms. So I'm going to look, there's a couple of questions. So medication has warnings for suicide ideation. Do you think that because we are prescribing more medications that cause SI that people are attempting more often? So again, I'm certainly not a medical provider. I think that that is a warning label, and we certainly know that for some medications more than others. And that needs to be an honest conversation. So this is where honesty and transparency is that if I'm working with somebody where there are side effects of suicidality, in the same way that if I'm working with a mental health patient that has suicidal tendencies, I'm having very honest conversations about them drinking alcohol, which is a depressant, which will increase the likelihood them of feeling depressed and attempting suicide. So these would be what I would say. I need you to pay attention to these. There's no shame in this game. Suicidal thoughts are incredibly shameful for individuals because we protect them, because we sit in secrecy too, right? We're afraid of them sitting and admitting that they're having these thoughts. So there are some medications that do increase the risk. We need to have very honest conversations with our patients, and we need to create space where they're not afraid of saying, I am having an increase in suicidal thoughts, that we then can work with the practitioner to make sure that we're adjusting the medications appropriately. How do you help clients when they don't know and recognize their triggers? Do you tell them? No, I don't tell them what their triggers are because I don't know what they are, and they probably don't either. So again, keep in mind that high heel moment. Somebody's going to get triggered by a high heel moment. I'm not going to know. The patient's going to actually think that the trigger was somebody cutting them off, right? So the way that I used to always say this is that there's a fire brewing and we're getting caught in the smoke. So we keep trying to brush away the smoke and like blow it away. We're like, right, getting rid of the smoke. And we're like, man, why does the smoke keep coming back? And I'm like, because you aren't going after the fire. I'm going after the fire, not the smoke. But I don't know what started the fire, nor do I care, but I need to figure out how for us to be able to get rid of the fire. So I don't need them to know all their triggers. If they know one, okay. But I need them to recognize the signs of when they are triggered, because that would allow them to re-regulate in the moment so that they have choice in response. That's the shift. And that is very clearly what I say to patients when they're like, well, how do I know what my triggers are? I'm like, I don't know. I won't know all your triggers. but I can help you to understand how to notice when you are triggered. Can we start with that? Because if you can notice when you're triggered, you don't have to do all that cortex level work of like trying to figure it out. And why does this happen? And why do I do that? I don't know. And you don't have to know that to be able to get yourself regulated, to be able to take that next step. And we will talk about that. So again, the skills needed to be able to respond versus react. We're going to touch on it today, but that is the next webinar. So when I talk about the strategies, let me be super clear. I'm not going to make you trauma experts, but there are some very simple ways that we can change the approaches that we have for individuals that have been impacted that allow for us to focus in on the regulation skills before the cortex level skills. We're going to focus on the limbic system before the cortex. And then how do we know when we can go to the cortex? So that will be that shift. Last question, I want to confirm that trauma is a risk factor for substance use. Yes. So the ACE studies, which we will show in a second, puts them at a higher risk. Yes, trauma increases the risk of developing a substance use disorder as well as mental health and psychiatric diagnoses. So when we look at the substance, so it is both correlationally and causational to both. When we look at the symptoms, so these are the symptoms of somebody that has been impacted by trauma and also the symptoms of somebody with a substance use disorder. So low frustration tolerance. So an inability to, so I always say in an inpatient, when you are 5 minutes late to a smoke break and you have a patient that is ready to leave treatment, that is a low frustration tolerance. We should all be able to tolerate a 5 or 10 minute delay. When somebody doesn't, I don't look at the individual of like, oh my gosh, like you got to be better. Like you got to be able to wait. Of course they do. We all know that. So why then? So I'm not angry for the symptoms or impulse control. I used to say in my past life, we had a patient that threatened to leave treatment because on our menu, we had chicken tenders or something like that for dinner. And that night we served fish sticks. And so they were ready to leave treatment because we provided fish sticks instead of chicken nuggets or chicken tenders. And what I witnessed is staff trying to rationalize. So keep in mind those 3 R's of a trauma-informed approach, right? Where we're saying you need to regulate first, relate, and then reason last. This staff member was trying to reason with them. Why would you give up your recovery for chicken and fish? Like, why would you do that? You're going to throw away all of these things. Yeah, that would be a rational thought. Somebody choosing fish sticks over recovery, that is not a rational conversation. So we don't need to do that. That is a clear indication that that person has been triggered by something. Now, what could they be triggered by? I don't know. But I've worked with patients that food insecurity is a trigger for their trauma, that they had to go through trash cans in order to be able to feed themselves when they were children. So could the change of food, again, keep in mind, trauma is not rational. It is within their bodies. It is a very quick conclusion to something that has occurred to them as an experience. So have I seen people that have looked at food as a pretty significant trigger? Yeah. So I'm not angry at somebody that's doing that. I'm recognizing why then this somehow has been related. So in the good old fashion of like classical conditioning, the idea of generalization, where something happens, but you generalize it to something more, food insecurity can be generalized to just a change in meals. That could be a trigger. Tendency to act rash, right? The reenactment. So sometimes, again, our patients will try and quote unquote provoke interactions with our staff that our staff become very reactive to. And I go, well, they got you. You are now recreating and reenacting their childhood. So if you are engaging in it, then you are now a part of it. And the patient is not intentionally doing that. This is a part of their system. This is a part of what they've learned. This is their normalcy. We are treatment, so we're trying to provide them opportunities to learn differently, right? So attention seeking, low self-esteem and self-blame. And so when I would say these things, I would say, so when we see a patient that looks sad or depressed, maybe crying off to the side, maybe isolating from their peers, what do we typically do? And most therapists will say, I go over to them and or any staff member, right? I go over to them, I see how they are, I ask if they want a glass of water, I ask if there's anything I can do to help. And I go, okay. And so when you do that, what typically happens for that patient? And they were like, well, they feel appreciated and they say thank you. And I said, did you cure them? Like, are they fixed? Like their depression is gone? And they're like, no, of course not. And I'm like, all right, but in that moment, you regulated them. And they're like, yeah, sure. And I go, okay. So those are the symptoms of depression: isolation, anhedonia, crying, sadness, isolation. When a patient starts cursing you out, when a patient is like, screw this, I'm not doing this, I'm out of here, this place is crap, but right? What do we do for that patient if we're being honest? And most people, if they're being honest, will say, I react, right? Whether you say, who are you talking to like that? You can't talk to people like that. You're being disrespectful. You need to do that. And I go, so we react to the symptoms of trauma. So while everybody says, I do really want to work with trauma, trauma's hard because our patients look different. Trauma is a lack of safety. And so if you've ever seen an animal cornered, do they become more docile or do they become more aggressive? A cornered animal becomes aggressive because it's survival. So when we see behaviors that look like survival behaviors, that is a trigger response, but we don't like them. We don't like those responses, so we tend to react because we're humans treating humans. And in our world, if somebody becomes aggressive, we react back. We get our defenses up. But in treatment, we can't. So if we can see, our patients don't get to choose their symptoms. They are diagnosed based on these symptoms. They don't get to choose that frustration tolerance is a part of a trauma response. They don't get to choose that poor impulse control is a trauma response. They don't get to choose those. This is a response to them having trauma. So us reacting makes them worse. This is why when they come back afterwards, they say they're sorry because they don't want this either. So us shifting to see this differently will allow for us to intervene with our patients differently. So when I see a patient that is threatening to leave treatment, I'm no longer trying to rationalize to them about why should they stay in treatment and how chicken fingers is not a reason to leave treatment. I'm just getting them regulated. When a patient doesn't attend group, I'm not yelling and cajoling them to get into group. I'm understanding it and I'm regulating them, helping them to recognize, man, something happened because today you're struggling to get into group. It's a shift in the way that we respond to individuals. That what I'm not going to show you is this video. If you on this call have never, and I can put it in the chat box, but if you have never seen the TED Talk by Dr. Nadine Burke Harris, I highly recommend it. It's about 15 minutes long, and she does an amazing job of talking about the adverse childhood experiences and its impact on the brain. I'm going to talk a lot about the brain in a couple of minutes as we kind of navigate through this, but this is a pretty important study. And so again, in the 80s, there was a study that was done by Kaiser Permanente and the CDC. And what they were looking at is health disparities, right? So health complications from adverse childhood experiences. And so they identified these 10 things as a condition of an adverse childhood experience. What this study then revealed was that ACE studies are incredibly common. So that was the first thing, right? So 61% of individuals had at least one ACE in their lives. And that about 25% of individuals reported 3 or more. What was so game-changing about this study was it was the first time really that we were able to look at trauma as a physiological event as opposed to just an emotional event, right? So again, I worked with adolescents, and so the things that people would say all the time is like, you have to like, don't enable their behaviors, right? We use these very kind of condemning words to identify what's going on for individuals. Like they're trying to get one over on you, and right. And really talking about this as like morality, much to the same way that we see that within mental health and substance use. And I was like, so that's not true, right? That there's a physiological experience that occurs inside of our brains when somebody's been impacted by trauma. So I'm not going to shame them for the game that they've learned, because what they've learned is survival. And what this study showed was it's not just about those behaviors, but individuals that had been impacted by trauma had higher rates of certain types of heart conditions, higher rates of ischemic heart condition, which is one of the number one heart killers in America. They had higher rates of obesity. They had higher rates of hypertension. They had higher rates of certain types of cancers. So this wasn't just that substance use was the result of trauma and kind of, right, which came first, the chicken or the egg. What it really revealed is that when childhood trauma occurs, when somebody is under that level of distress, it quite literally changes the brain. That's how we get our symptoms. So when we talk about our symptoms, and sometimes we're like, well, how come some patients are like that all the time, right? More reactive, more responsive, more, impulsive, and some patients aren't. The way that I would always say it, and this ties into the adverse childhood experience, is that some of our patients are 20 miles into the forest. And if you're 20 miles into the forest, there's only one way to get out. It's 20 miles. Some of our patients are only 7 miles. So if you're only 7 miles in, it's only 7 miles to get out. So comparatively speaking, if you're the patient that's 20 miles into the forest, what's the difference between that person and this 7 miles? Oftentimes it's trauma. So that means if you're 20 miles in, you're more likely to get frustrated at the fact that there's a 10-minute break or 10-minute delay in your smoke break. You're more likely to get reactive to other individuals within your community. You are more likely to get frustrated or to be impulsive because you were 20 miles into the forest. If we don't understand the trauma-informed approach, then what will happen is that we will miss the fact that that person that was 20 miles into the forest is now 13 miles out. And while they're not out of the forest yet, right, this might account for like the multiple treatment episodes, they're still making progress. They're still moving through the forest to get out. And so I'm never going to shame somebody's recovery. I'm also never going to compare it. But I do want them to understand, listen, if you have, and that's where that adverse childhood experiences becomes important. If you're working with somebody that has had a history of trauma since they were in childhood, then be prepared for when you pull off that scab, what it's going to look like underneath. Don't be shocked. Don't look at somebody that has just a little cut and ask them what's different about them versus the person that you opened up a scab. Those are two different injuries. One is going to look worse. That's the shift in the understanding of the difference. And so again, if you have not ever seen this video, I highly recommend that you look at that. Dr. Nadine Burke-Harris, Adverse Childhood Experiences. It's a TED Talk. So we're going to talk a little bit about the brain. Dr. Burke talks a little bit about the brain as well. But when we start to talk about the brain, it becomes incredibly important in our understanding, again, because I'm not condoning nor am I condemning behaviors, right? We're treatment. And so we're helping an individual to be able to recognize when they are being activated or triggered, to provide them the tools and the skills to get themselves re-regulated so that they have the choice to respond, so that they don't continue to make the same decisions if those are decisions they want to change. So when we look at how our brains develop, it develops from the bottom to the top, from the back to the front. At the very bottom of our brain is our brainstem. That part of our brain is where all senses first acquire their entrance into our brain. So you think of how much stimulation is coming into your brain, how many different senses at any given second are running through your brain. That brainstem has to make a decision as to what to do with it. So when we talk about somebody that has active flashbacks, it's because something in their environment came through the brainstem, which is where it's making the decisions about what this is. In that moment, it makes a decision. Is this a threat or is this nothing? Because if it's a threat, it's going to send the message differently through the brain than it would be if this was just a sense that it was like, I don't even have to pay attention to it. That's where history comes in. So this is why one person's high heel moment is another person's loud sound. A very visual example is that not too long ago, there was unfortunately, there was a shooting in a high school football game. In that moment that they showed it on the TV, I remember saying, we are watching different people's brains as a response to this. Because when you looked at the students who were on the field, there were some that dropped to the ground immediately versus some that were literally looking over their shoulder and around, being like, what was that? What was that noise? That same sound came through the brainstem, and based on history and experience, that brain either said, shoot this information to the limbic system, which is your fear response system, and you need to drop right now, versus somebody else whose brainstem had no history of acknowledging this as a trauma and sent it straight up to the cortex, where they were like deliberating, like, huh, I wonder what that was. That was a weird noise. What the hell's going on? That's the shift in the way that trauma impacts our brain and our messaging. So at the bottom of the brainstem, also in our brainstem, is also basic physiological experiences. So I always say in the inpatient world, it's your heart rate, it's your respiration, it's your digestive system, it's your sex drive. If you are under a tremendous amount of stress, high levels of cortisol and adrenaline, you will notice in yourself, down at the root of your brain, you have been impacted, right? You're not sleeping as well through the night. You're craving really high comfort foods, right? Your digestive system is changed. That means that your body is being distressed. As your brain continues, and personality can impact that, right? So certain people are a little bit more sensitive to the experiences of the outside world. But as your brain continues to develop, we have the limbic system. The limbic system is the emotional part of the brain. It is where the fear response system, so that amygdala, sits. It is where the hippocampus sits, which is where the brain says, do that again. So did it work? Do it again. And it is also where the nucleus accumbens sits, that says, this was a reward, right? So your brain gets rewarded in this small emotional part of the brain. This is where I will say, most of the behaviors that we see in individuals seeking treatment for sit in this limbic system. At the very top of the brain is the cortex. The cortex is the rational part, the reason part, the weighing your consequences, thinking through your choices, right? Being able to deliberate and say, like, this is not worth my life. This is not worth losing my family. This is not worth losing my job, right? That's the reason part. That's the cortex. But we are created to survive. So in a world of survival, if someday, and so Dr. Burke talks about this as far as our brain is organized, again, in a mechanism of survival. So she talks about it as a bear going into the woods. If you are in the woods and you come across a bear, very quickly, your brainstem shoots up messages to say, what do we need to do? If you've had a history of bears, coming into contact with bears, it's going to probably direct it in a different way because you have history to be able to do something different. But for the majority of us, very quickly, our brainstem says, this is terrible. We could die. And so what it does is, in survival, it sends a message up to the limbic system, to the amygdala, right, which is basically the smoke detector of the brain. And it says, you need to either fight or flee quickly. You need to make that decision immediately. What it doesn't do is shoot that message up to the cortex, because the cortex, you don't need the cortex trying to weigh the choices for you, because you need to make a decision in the moment, immediately, to survive. So your brain is either going to make a decision of like, I'm either going to try and fight this bear or I'm going to run. So what it does to the cortex is it actually shuts it offline, because it doesn't want the chatty little cortex trying to be like, I don't know, what do you want to do? Like, do you want to run? Do you want to like play dead? Like, what do we want to do? What's going to be the best? The limbic system is like, you will get us killed. So it shuts it down, like construction, boom. So the way that I normally tell this to our patients, as well as individuals when I'm working with them, is that I'm like, it's almost like asking for Wi-Fi on a flip phone. When a patient is triggered and you can see that they're in the limbic system, when you try to reason with them, it's like asking somebody to access Wi-Fi who is using a flip phone. You can keep asking them, but eventually what will happen is that you're either going to get them pissed off enough that they react to you, which is what happens most of the time, or You will shame them because they're like, I guess everybody else is able to access Wi-Fi, so there must be something wrong with me. So for that limbic system, that smoke detector, so the more trauma happens, what is supposed to be adaptive becomes maladaptive. So again, if we use the high heel moment, right? You are in a threat. Your brain is supposed to flood your body with adrenaline and cortisol, right? It is supposed to flood your body so that your extremities are in a position to either fight or flight. But when trauma happens, the system is overtaxed. And your brain is consistently. So if those high heel moments, if I was an abusive mom, the brain is consistently getting flooded with adrenaline and cortisol, which depletes the dopamine, which depletes serotonin. And as a result of that, you become a more limbic system dominated person. And so figuratively, not literally, that amygdala, which is the fear response system, gets bigger and bigger. And so that's the individual that is more responsive to other people's voices, that's more responsive to a 10-minute break, because their brain is so sensitive to the environment that everything is a potential threat. So they pay attention to everything. Trigger, 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 trigger. That's the difference. So when you say, why does one person look like that 90% of the time and one person look like that 10? That's where trauma changes the brain. That becomes the shift. So when in a trauma-informed understanding of a patient's experience, when the cortex is online, so when somebody says, well, how do I know if the cortex is online? I'm like, because they're talking about their future. They're able to say, I really want recovery. Oftentimes what you hear is people being like, they don't care anymore. They're not invested, right? Every patient that accesses care wants to get well, period. Some are afraid that it's not for them. Some of them get triggered. And then the phrase that I used to use when I worked with adolescents, kids would rather be bad than stupid. So if we don't give them opportunities to understand themselves and they think that they are stupid, they'd rather act out in class. If you have somebody that starts to question whether recovery is even possible for them, they will start to tell you they don't care. Why would somebody access care if they didn't want it? Even those that are like, well, I only did this so I didn't have to go to jail. I'm like, yeah, I hear you. That's still a choice. So I'm going to say every person that accesses care wants recovery. Our jobs is to help them to keep connecting back to it. If they are future oriented, if they are in their cortex, they can think about their future. The second something triggers them and they drop down to their limbic system, they are living in moments. And if you think about moments, what does 2 months down the road mean to me if I'm actually only going to survive this moment? Because perceived threats and real threats elicit the same response to the brain. Perceived threats and real threats elicit the same response. So if I use that high heel moment, standing in the lunch line, that is a perceived threat based on the history. So that brainstem heard that high heel, instantly said this is a threat, and they reacted as if this was a threat. That was a perceived threat. And it did the exact same thing as the actual threat when there was abuse happening. That's how somebody can get in that moment. So once we see that somebody has been activated, the lower region of the brain has no networks that link time or consequences. That is why it doesn't work when you try to get them. Don't you want recovery? Don't you want to do things different? You can't. Because the brainstem and the brainstem and the limbic system do not have networks that allow for them to tell time. So that's why they can't tell the difference between an active flashback versus something that's happened in the past. That's why somebody would react to high heels versus being able to rationally say, man, that high heel actually triggered me and I didn't realize it. So again, understanding it becomes that when we understand how trauma impacts it, just means that it's an unbalanced nervous system. All of us act the same way. So when our sympathetic nervous system, the fight or flight, gets activated, we all act in a similar fashion. All of us. So if you've ever been driving and somebody cuts you off really quickly, your nervous system automatically is activated, right? You get agitated, you turn down the music, right? All of these things occur. But then what happens is that the parasympathetic nervous system is supposed to kick in the rest and relaxation, right? Where you go, man, that was scary. That person cut us off. Or somebody that has experienced trauma, that sympathetic nervous system keeps getting activated over and over and over and over and over. And so they become limbic system dominant. So they feel agitated most of the time. They feel distressed most of the time. They feel impulsive and reactive most of the time. That's their brain showing that they're in there. So again, when I've worked with teenagers and I would say, all right, so who do you think you are, right? Let's describe it. And they would describe themselves. I'm angry, I'm aggressive, I'm reactive, I'm violent. I don't care what people think, right? All of these things. And I go, all right. And I write it all down. And then I say, how would I describe you? Would I describe you the same way? This is where patients will oftentimes try to assign their recovery to a person because they'll be like, Trish, you're different. I'm not different. How would I describe you? And they start describing themselves. Well, you think that I'm nice. You think that I am thoughtful. You think that I'm funny. You think that I'm, right? Whatever they describe themselves as. And normally what I will do, and we see this in like the therapy world, because sometimes people will do the two masks, right? The two masks of who I am, as if it's like Dr. Heckle and what is it, Mr. Hyde. And I will caution everybody so that we don't have patients thinking there is actually two versions of themselves. Actually, what it is the one is just showing that you're triggered. So when they say these are who they are, I go, this is who you are when you're triggered. That's actually who we all are when we're triggered. If you feel that that's how you are most of the time, it means you're triggered most of the time. Who they are that we see them as, right? This person that cares about other people, this person that wants recovery, that's actually who they are in their cortex. So if we are hardly seeing that, that means that they're not in their cortex most of the time, and most of their time they're sitting in that limbic system. That's where the work begins. So I'm not doing a lot of cortex level work. They're not even in their cortex. I'm actually going after their limbic system. This is similar to what we had talked about. So again, when we talk about the comorbidity of trauma and substance use, again, keep in mind, it doesn't matter if the substance use is the solution or if it's something else. This is the way that we would perceive it. So when you're looking at this, you can see for most of our patients, they are in their limbic system. That is the dominant part of their brain. So if we are doing cortex level work for a limbic system dominated brain, this is where you will see the disconnect where our patients will say, I don't know why I did that. I don't know why I did that. I know I should have done something different. Because they know the cortex level skills, but they need skills to be able to regulate their limbic system first. That is the shift. So I think there are a couple of questions. So in regard to teaching the client to respond, not react, it seems solution focused. Yes. Is this where the normalization happens? Is that they don't need to understand the why they are feeling, thinking, just the fact that I am feeling, thinking whenever activated? Yes. In the beginning, right? So because we won't know and because they don't know. So for those of us that have worked in recovery for long enough, early recovery, your feelings aren't factual anyway, right? They're driven by an emotional center. So you see somebody, right? I always take it back to like, let's just say yourself. On the days that you wake up and you're already grumpy, aren't those the days you're more sensitive to the world? So that's the day that you're like, why did you say that? Right? That's the day that you feel slighted at work. That's the day that you're angry at your spouse because you felt like that they didn't do enough. But those aren't actually facts. That's that you were already grumpy. Your limbic system was already activated. And so you're perceiving the world differently. So in early recovery, it's not that I'm diminishing somebody's feelings or emotions. I'm helping them to trust they're not always reliable in the beginning. So I need you to get yourself regulated before we start making decisions. And I don't need them to know that why yet, because they might not know it. How am I going to get somebody to understand those high heel moments? but can you recognize when you are feeling it? What does it feel like in your body when you are stressed? What does it feel like in your body when you are agitated? That's what I need them to start with. So yes, they don't need the why yet. If they decide that they want it, this is where a full continuum of care is so critically important. If they want to continue to figure out that why, this is where you do it. But again, the best analogy that I can say is that a full continuum is basically like training for a marathon. When you come into an inpatient and you say, I want to run a marathon, I'm like, I love that journey for you. I'm a fan. Like, I want you to run that marathon too. But if we were to set the patient to go run a marathon within the first week, we would be setting them up to fail. So when we look at like what the importance is of a full continuum, it's that in those inpatients, we're training you on what it means to get your body ready for the marathon, for the run. So we're like, do you drink water every day? No. All right. Well, we're going to start with that. What about your diet? Do you have enough protein? Do you have enough carbohydrates? No, I don't really eat any of that. And you're like, okay, well, we're going to start with that. How about sneakers? Do you have a pair of sneakers? They're like, nah, I got flip-flops. And you're like, okay, so we need to get you some sneakers too. That's inpatient. We're providing you the tools and the knowledge that you need to be able to continue to train for a marathon. So that when you go into your outpatient, your PHP and your IOP, they start saying, all right, let's start doing some light jogs. We're going to get you to run 2 miles. Then we're going to get you to run 5 miles. That's how treatment should look. The way that it currently is set up is that a patient comes in an inpatient and they're like, I want to run a marathon. And we're like, do it, go outside and run that marathon. And they don't have sneakers on. They don't have enough water in their body. They don't even have protein in their body. And then they beat themselves up because they were like, I can't run a marathon. And you're like, you can, but you actually need to know what you need to do for your body first. Then you train to actually start running. That's how a full continuum should look for our patients in the experience of trauma. I want to confirm that trauma is a risk factor for substance use. Oh, I did that one. All right. And then you're encouraging in the why then. Question to use a tool of leaning in on the skill of curiosity as part of regulating. So I will say one of my best skills is that, and this was coined by a student that I was teaching, I am compassionately curious. They were like, that's what you seem like you are. And I was like, well, that's nicer than the way that I normally say it. I am constantly curious. Not about that why, like, how did you get here, right? But like, that's different for you. Like, have you ever noticed that? Like 10 minutes ago, you were okay. But then when the smoke break happened, like that was definitely different for you, right? Do you feel that? Do you notice that too? And they say, yeah, that one really pissed me off. And I go, all right, I don't know why yet, right? I don't know why that really bothers you. But like, I wonder if that's an opportunity for you to start getting regulated. Like, I wonder if that's an opportunity. If you're going to call your family and you're like, I avoid my family. And I go, I wonder if that's going to get in your way, right? I am constantly curious. I like compassionately curious better. That's a nicer way to saying it. But curiosity in a direct observation of patients' behaviors of like, hey, do you notice this is happening to you too? Do you notice when I take you outside, every time we go outside, you seem to calm down? Have you ever noticed that? And they're like, yeah, I do actually notice that. What I end up saying is that, so I wonder if that's one of your skills, right? The skill is that you went outside. The skill is the sunshine, because if we don't call these things out, again, in a triggered state, the brain makes very quick conclusions. Your patients will say it was me. Well, Trish is the only one that makes me feel safe. Trish is the only one that can de-escalate me. No, I just opened up an opportunity for you to engage in a skill. And again, because I don't want to institutionalize people, I want them to know the skills are all in their own tool belt. But I am not one of the tools. So I am always going to put it back to like what I noticed worked. And it can't be me, because if they think it's me, they have to keep using in order to get me. So when we talk about you are the captain, we are contagious to the emotions of others and continuously scanning the environment for signs of danger. If we are distressed, our patients can't find safety, period. So to the point earlier of the transference, it's incredibly important that we start recognizing what brain state we are in. We are humans treating humans. And so sometimes our ACEs can get triggered by our patient's ACEs. So it's incredibly important for us to recognize, hey, which patient am I responding to the most? Which patient makes me want to react? Which patient am I avoiding? Because that's an opportunity for us to have as colleagues, as supervisors, to be able to support the journey because our patients are scanning us. And if they see us as not safe, again, I like analogies for whatever reason, but I always think I fly a lot. If I saw panic on the face of my pilot, it wouldn't matter if the pilot was like, no, 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 everything is fine. Everything is fine. I'd be like, well, why does everybody look stressed? Why does the flight attendants and you look like you are stressed, but you're telling me things are fine? I would be getting off that plane. Those are your patients when they leave against advice. If you're telling them everything is fine, but you don't look like it, then they're going to trust what they see, not what you say. So how did we get here? So again, research on the brain showing that addiction is a matter of memories and recovery is a slow and hesitant process. So this is where, when we talk about the full continuum, so for anybody on this call that's like, I don't know, I mean, I just tell the patient they should go to aftercare. It might be helpful. This is actually the research that says, stop saying that. Make sure that that patient understands, listen, addiction is memories that happen relatively quickly. Recovery is very slow. So this is why you need to make sure that you're staying within that full continuum, because things are going to pop up that you're going to need to be able to continue to learn as you navigate this process. There's going to be a couple of slides that I am going to skip. This one of them because we've already talked about the limbic system and the prefrontal cortex. The piece that you need to know, if they are in the limbic system, it is fast. This would be the difference between a text message and an mail in the US Postal Service. So if you're trying to get to the cortex, consider that putting it in the mailbox. If you're trying to get to the limbic system, it's very fast. It's a text message. So that means that the impulsive part of the brain is going to be responding much quicker than the thought-provoking part of the brain, particularly when they're triggered. The genetics of addiction. So again, nature versus nurture. So we know that there is the environment that is also going to be a part. That's where trauma occurs. That's where a safety of an environment, that having care where safety is ensured, it allows for our patients to start getting themselves regulated. Safety is regulated. This is why our patients, and we hear people say this all the time, our patients feel so safe. They always do so well in treatment. And then you talk to the family and they're like, they always do well in treatment, but then they come home and it's a hot mess. And you hear the family's anxiety because treatment providers keep saying, well, they did great in treatment. And they were like, great, that's not where they live. They live here. And every time they come home, they are not as safe. That's where nurture comes in. This is why the importance of family becomes so critical, so that we are able to assign and assess safety in all levels for both the family and the patient. And then nature, there are some studies that highlight how some brains are more susceptible to addiction. So again, adverse childhood experiences, that is going to increase the predispositions for somebody with addiction. Nature also does it. So what they have is they've identified an external stimulator and an internal stimulation for brain. Those externalizers are oftentimes higher risks and propensity. So we see that with like an ADHD brain is certainly going to have a higher risk. So what does this look like in our patients? So I'm going to very quickly go through this one. This is what it looks like if you're patients. So patients that are constantly in need of nursing, again, if I'm not trying to institutionalize somebody, then if our patients are consistently trying to access nursing, then I want to bring that up. That's mutuality, that's respect, and that is transparency, that I'm just going to say, listen, we're about to discharge you in a week, but every day you are coming in to seeing nursing. And so I'm worried about what that will look like when you get discharged, because you won't have access to a nurse 24 hours a day. So what other skills can we put in there to be able to help you? What other things? Because what I don't want your brain to learn is that every time I get really agitated, I go to a nurse, because that's not sustainable recovery in the real world. I want you to be able to intentionally and appropriately utilize medical interventions in a way that's going to support your long-term recovery, not just the recovery while you're in an inpatient treatment facility. So when somebody says, so how do I know if they're triggered? If they look like this. If you see any of these behaviors, know that they've been triggered. So if they look angry, aggressive, defensive, reactive, impulsive, if they're hitting, if they're tantruming, if they're fidgeting, then they've been triggered. That's it. How do you know how far they've been triggered? We're going to talk about that because you're going to hear it in their sentences. So I can get triggered. I can look really angry. I can look really reactive. And then I can very quickly get to myself back to a cortex, right? I can start to rationalize. I can be like, all right, this isn't necessary. I don't need to be this responsive, right? I can kind of go back and forth. You're going to know that somebody is further into their limbic system when you try to be rational and you piss them off. Then they are further in their limbic system than you thought. And at that point, we're going to go after the limbic system responses instead. But so I will say I had one person when I was doing this training, they said, what if the patient is just, so excuse the language for a second, I did a pretty good job of not having any inappropriate language, but I had somebody that said, and this was their quote, what if the patient is just an asshole? And I was like, what if? I'm always going to err on the side of that we engage in behaviors that we've learned have worked. And so I will quote my mom, if there was somebody that you genuinely are like, I just think that they're an asshole, then I will say what my mom said, which is, then just be glad you're not married to them. But they still deserve life and they still deserve recovery. And again, we are not here to condone or condemn behaviors. We are here to provide opportunities for people to choose recovery in a way that is safe. But I am always going to defer to that this is likely a traumatic response and that our preconceptions of what somebody is and isn't is probably generating if we think somebody is an asshole. Here's the behaviors of the sympathetic nervous system. So this would be what we call freeze. So I'm not going to go into freeze as much. I will likely go into it a little bit more in the next training, but freeze is a system that is a result of fight or flight not working. And so it comes out of a different part of the brain. It's a dorsal response system. So it's passivity-oriented behaviors to mitigate the behavior. So fight or flight is a aggressively oriented behavior, right? An assertive oriented behavior to mitigate the behaviors, right? I'm either going to fight you or I'm going to run. Freeze comes in, and this is where we see somebody with attention seeking. So this would be what other people would be like, that person's acting so borderline, which I won't even get on my soapbox of how much that actually bothers me when people say that, right? When we as the practitioners pathologize people. So I will encourage you to stop doing that as well. Is freeze comes out of a position where fight or flight didn't work. So if I am a child who could not fight back and I had nowhere to run, then I freeze. If we think of it in the wild, a possum plays dead because it's not going to be able to fight its prey and it's too slow to outrun it. So it freezes. Now, the messaging of that is that the inconsistencies of me being able to figure out how to provide safety means that I have to disassociate, which means that there's inconsistent understanding of how to get my needs met. And so when we hear people saying they're so clingy, they're so attention seeking, that means that they haven't figured out how to get their needs met. And this is what they've learned, is that they have to like fight for it and then they have to back off. Additionally, freeze can happen for one person who also displays behaviors of a fight or a flee because it's situationally dependent. So for a young man that I worked with who was working with me because of aggravated assault charges, he obviously was a fighter, right? So he did not flee, he was a fighter. So he had a lot of aggravated assault charges. This is why he was working with me. When I brought his mom in, who he was very close to, so this was a young man. And again, when we understand like not to shame behaviors, because all behaviors serve a purpose according to the brain, all behaviors. And we are not in a position to be able to shame somebody for a behavior that they learned worked. So here's a young man with aggravated assault charges. I am not condoning that. but I am not condemning it because when I understood where his behaviors were, this is for a young man that at the age of 5 started to have to be able to physically protect his mom from violent acts against her. He grew into a very big young man. So he was able to successfully, quote unquote, protect his mom. Now, that's where his aggravated assault. So every time that he heard loud voices, every time he heard chaos, every time he heard a loud man's voice, his nervous system automatically reacted. My work was not in the beginning figuring out that this was all occurring because he was protective of it. Mine was, do you notice when you're getting triggered? Because you just punched a teacher. So do you notice it? And he was able to start saying he noticed when he would clench his hands, right? That's how we were getting him to start regulating first. Freeze showed up when I brought his mom in. Because the second mom walked into our office, he shut down. Literally shut down. Here's a 6'2" young man who curled up into almost a fetal position. So he is a fighter that learned how to freeze as well. So patients can be both. This is going to be where I leave my last slide. And again, the the support for the strategies and the interventions. Again, I'm not going to make all of you trauma experts, but it will certainly be enough that you are able to integrate some of your interventions with patients in that next training. But the importance of brain states. So it's incredibly important for us to be able to understand where we are. That's super important, but also where our patients are. So how do we see that? And again, I will say I very clearly look at somebody based on their behaviors and their timelines. So if I work with somebody that has suicidality and I say, how are you today? What are you going to do later on tonight? I'm asking that question because I need to hear what she answers me. Because if she's like, I don't know what I'm going to do tonight. Jesus Christ, Trish, why would you ask me that question? I'm like, okay, so she's pretty low down in the midbrain. If she says, you know, I don't know, Trish, I'm just really depressed and I'm feeling really agitated, but I know I'm supposed to go to the gym, so I'm going to go to the gym. I know she still has the capability of dipping into her cortex. That's relatively easy to be able to figure out with our patients. So when you see somebody that is calm, so in your one-on-one sessions, sometimes in our groups, when they are laughing with each other, they're calm. They're future-oriented. They have the ability to problem solve. That's where you can provide them some skills and some tools, but they need to know those are the right tools for when you are calm. The problem with most of our patients that we haven't done is and I revert back to those 5 skills that we've said, right? Every one of you. So there's 400 of you on this call. So thousands of patients that we've worked with. And it's the same 5 skills. Our patients are walking around with a bunch of hammers and feeling like, why can't I build this house? I'm a failure. I'm never going to be able to build this house. And I'm here to say you can build the house, but you can't with just a bunch of hammers. If they only have cortex level skills, nobody's going to be able to breathe out the urge to use heroin. That doesn't exist. Breathing is a great skill. That's a good tool, but it is not the only tool, and it is not the right tool if you're about to use a substance. So when you start looking at the limbic system and building those tools, the limbic system is when the brain is in the alarmed phase. It is triggered. They are more likely to be emotional, and you will know that they are there because they are hours within seconds. We'll tuck away the midbrain to just focus in on that limbic system with the alarmed and fearful. They're either in hours or they're in seconds. I see that, and I know if they're in hours, I know they're closer to the cortex, so I can do a little bit of regulation skills to get them back to the cortex. So sometimes you will hear your patients say that these don't work. And I'm like, they do work, but if you are in seconds, it means you have to do maybe 4 or 5 skills to be able to get closer to the cortex. Whereas if you're in hours, maybe you only have to do breathing and you only have to do some stretching, or you go outside and then you notice that your nervous system calms down. But if you're down at midnights, you might need to do cold water on your face. You might need to do some strenuous exercise. You might need to breathe as well. You might need to layer it to get yourself closer to that cortex. And so I need our patients to start understanding the importance of a lot of tools and what each tool, so that they're not walking around with a bunch of hammers being like, these aren't working. A hammer works. It is a great tool, but it alone cannot build a house. Our job is to help our patients to understand which tool to use for which brain state, and then how to use them and how to recognize when they need to use one. So our patients should also understand their brains and where they are. So with that, I think we have a couple of questions. If there are other questions, please put those into the chat now or the Q&A so I can answer them. How important is diet and nutrition in one's neurological health? Yes, very. So again, diet and nutrition is always going to be important. If we talk about it in a physiological experience, I like to say, like, listen, I want you to be a detective to your own recovery. If all of a sudden you start craving sweets, comfort foods, salts, then I need you to know your brain is already starting to warn you that it's feeling distressed, right? That it's a recognition of like, I don't have a lot of serotonin and dopamine. And so, you know what, if you just get some mashed potatoes, a chocolate chip cake, and McDonald's, I'll feel better, because what that will do is it will flood the brain with some of those neurotransmitters, but then they go away. And so I like to highlight nutrition and diet, not just in like overall wellness, which is fantastic, but in early recovery, that can sometimes feel overwhelming, right? So I'm going to educate them on it, but I also just need them to recognize this as these are some of your signs. Don't wait for the actual trigger because it's a perfect storm. Reoccurrences don't happen out of nowhere. That's a terrifying thought for our patients to feel, that I don't know why this happened. I want them to know these are some of your warning signs, and nutrition and diet are part of their warning signs. You start craving those foods, know your body is under distress. You start changing your diet, know your body is under distress. You start noticing the change in your sleeping, in your bowel movements, that's your body saying, hey, 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 we're starting to feel distressed. And those are the times to get yourself regulated so that you don't wait for the crisis, which is typically what our patients start trying to use skills for. They wait for the crisis to try and start using a skill. And most of the skills are cortex, and they're way too out of date for that. Do you provide this training to nonprofits dealing with people in the community? Yes. I would reach out to either Callie or Promises. Danielle Garcia is on this call as well. So if you want, you can connect to them and we can figure something out if that's possible. This level of trainings for people in counseling field. Yes, community health workers, yes, would be a benefit for this as well. Any different for people with autism? Yes. So autism is a little bit different just because, again, it's a different part of the brain. So without going into much more detail, it is a little bit different. There are some things that would be supportive for somebody with autism. And so you will see that within like the tactile, and they are more of the interventions are directed towards that limbic system, right? So more of like not going after the reasoning part and more looking after the toe to toe and the limbic system piece, but still a little bit different. I guess that's because sometimes people with ASD have addictions to chemical. Yes. So yes, the social connection. So again, I won't be able to answer that. It's a pretty big conversation, but some of these skills are going to be very effective for somebody with autism, but there is a lot more that would need to be integrated for somebody that struggles with autism, again, because it's such a large spectrum disorder. It would matter the severity of it and kind of what we are looking at. So I'm going to skip over a couple of slides of skills for the brain states. I am going to end with, again, for those of you that are interested, we do have open positions. I hope that you found value to this. I hope that you are able to take some of this away and be able to utilize it in your practice today. I hope that you are interested. If you are interested in being part of our team, I am super excited about the work that we are doing here at Promises and the clinical movement that we have been able to do over the course of the last year. So I'm incredibly excited about that. These are our next, the next webinar will be hosted by me on practical applications. So we'll be talking about these brain states. So I encourage you to sign up. I hope you found value to this. I am greatly appreciative of your time and have a wonderful weekend no matter where you are.
Thanks,
Callie,
Trish.
did I lose anything?
No, I think you did great. I put the links to those February and March webinars in the chat, and then I'll be sending out the surveys just after this. Oh, yeah, I think that was it. Thanks, Trish.
Thank you, everybody, and thank you for all of the work that you are doing. I appreciate you. Next time I'll have my camera on. So sorry about that. All right, I am going to stop sharing and then I am going to end this. If you have any other additional questions, please feel free to reach out to us. I look forward to being able to be a part of the conversation next month. Have a wonderful weekend, and I am going to stop sharing and end this.
Thanks, Trish.